let's use my own phone.
The tension's killing me.
Oh.
It says it's live streaming on my computer.
Yeah, me too.
Yes, and it is live on my phone. Excellent. It's always the worst bit. You never know whether you're quite live until you definitely check.
Technology works. Yeah.
Exactly. So good evening, everybody, except for Leah, where it's very early in the morning for her. So thank you for that dedication. We are talking about the Physical Therapies stream this evening. We do have Benoy Matthews joining us as well, but he's just having a little bit of a technical issue with his Zoom account, so I'll let him in a second. So I am joined by Thomas Mitchell, Matt Scarsbrooke, Chris Norris, Leah Dwyer and Paula Clayton from the Physical Therapy stream, and we're going to have a bit of a chat about the topics and the agenda that was released today. So that's all very, very exciting. So hopefully everybody's nice and well. I've certainly got a beer with me. Leah hasn't got any alcohol with her. It's a bit early in the day for her. But thank you everyone for joining me.
Good.
Good morning.
I've got squash.
Matt's got squash. Are you training for something, Matt? Or
No, the kids are still awake, so as soon as they've gone, it's on.
At least he's not making bread now.
Yes, that's true.
I've saved that.
Aha, so we've got Benoy with us.
Yeah.
Have you got a camera as well, Benoy? Or
Yeah. Let me see.
yeah, no worries. Okay. There he is. Hiya. Okay, so we are live already, Benoy. So we are just going to crack on, just going to talk through everybody's titles and see what they are going to present on. So Thomas, you're top left of my screen. So we're going to start with you, if that's all right. And I'm going to pull up the titles of the, what's happened here? There we go. Pull up the titles of everybody's talk so we can be reminded. So Thomas, just take us a little bit, tell us a little bit about yourself, and also tell us a little bit about the talk that we're going to do with you on the stream.
Thanks very much, Jack. My name's Thomas. I'm a physiotherapist. Been a physiotherapist for over 20 years now. I'm a wrist and hand specialist, so I'm the clinical lead for a private organisation called the One Health Group, and I'm the lead for their wrist and hand service. As well as that, I'm a private practitioner. I'm also a first contact physiotherapist in primary care. So I've got a number of hats. I've got a very keen interest in rehabilitation, and within that, I teach as a Mulligan concept teacher. So I'm very interested in mobilisation with movement. I also teach on the upper limb with Andrew Cuff on our complete upper limb course. The talk that I'm going to do is reasoned application of self-mobilisation with movement. And this is an area where I'm particularly keen and particularly interested in getting across, because especially under these times of altered working with COVID, our ability to work in that up close environment has certainly changed. And also in terms of what I'm hoping to achieve with my patients, it's using things like mobilisation with movement as a useful adjunct to the general care that they get when they see me in clinic. So yeah, it's been an interesting process seeing how adjuncts such as MWMs fit in with a modern clinical picture. And that really reflects my own journey through my career. So I've been going for 20 years. And if you looked at me as a practitioner 15 years ago, you'd see a young man who was doing lots of passive treatments like manual therapy or acupuncture or electrotherapy. And really, as I've evolved through my career to roles of more responsibility and clinical decision making, and also getting the ethos of self-management reassurance that I find self-mobilization with movement really provides a useful tool for some patients to help them on that journey towards independence and recovery in their conditions.
Brilliant. And I know we've got, you're going to probably talk a little bit more on the upper limb with the MWMs. Is that where you would find, I know you're an upper limb specialist, but is that where you found it most useful, that type of technique?
Yeah, like I find as we get towards the periphery, I find things especially useful. So certainly there's techniques that are really great regarding, well, tennis elbow, obviously, using self-NWM as a modulator of pain to allow people to load up and get the benefits of tendon loading. I think that certainly is something which is useful. Also using tape in that environment, so potentially using diamond taping, which is a Bilvicin-Zeno technique, and I think that's really useful. Right the way to the wrist and hands, and you know, there's things like a scapholunate instability, where when people fall onto a wrist, they can cause instability between the scaphoids and the lunates, and the scaphoids can pronate and flex. And I find that if you use a tape, you can, well, I can't say that you're repositioning the bones, but you certainly seem to have an effect which helps people engage in their rehabilitation. So yeah, my biases are towards the upper limb, and that's where I see the majority of my patients. But you know, I am a generalist physio as well, so anything that comes through the door, I'll approach. But yeah, we have many things in our toolbox.
Perfect. And you've set me up perfectly to go on to Chris and Paula in a bit as well. So we're next on my screen, we've got Matt, and there's a little bit change of pace, but certainly, I can't remember, I'm going to pull the agenda up in a minute, Matt, but I think me and you might be on at the same time, which I'll be annoyed at if that's the case, because I really want to come to your talk. But you're certainly...
I'm the agenda.
Oh, I know, I've made errors left, right, and center. Certainly one of the things we wanted to get onto the conference was these sort of therapies where there's been a lot of negative press, shall we say, across social media about different things and where they fit, and you know, should we use them and what do they do and all these kind of things. It was something we were really keen on, and Leah's going to touch on this as well in her talk. So tell us a little bit about yours and how that's going to help us in practice as well.
Okay, so I'm a soft tissue therapist, but I have only been in the industry or in the field for a couple of years now. Second career for me, previously in the corporate world, and I can assure you this is way more fun. Yeah, so soft tissue therapist, studied with the ISRM, and now work both. I've got my own clinic, and I work with a team of physios and sports therapists out of Bristol Physio as well. And predominantly, I do manual therapy, which, as you've alluded to, is something that is definitely not flavour of the month with some practitioners, and I think for good reason. You know, my background is science-based, and so when I first started, and I sort of started studying with the school I trained with, and I think quite early on they were like, so massage doesn't do what you think it does. And actually, we've got very little evidence that it does anything at all. I was like, what? Because I'm like, hang on a second, I've paid you for what now? But actually, that kind of approach was really refreshing. And I think it started me off on a really good track to dive a little bit deeper into, okay, so what's going on with massage? And yeah, effectively, my talk is around my interpretation of the current evidence and where massage has a role in taking someone who has either acute injury or chronic pain through to, you know, through their rehab process. I'm definitely not someone who cures all ills with my hands. That is, you know, I do strength and conditioning with my clients. I don't touch on electrotherapy. That's probably an area that I haven't dared tread yet. But in terms of hands-on, one of the things that I found particularly interesting, certainly from the research, and this is kind of a guide in towards where I'm going in my talk, is obviously if you judge the quality of, or the success, should I say, of a research paper on the number of citations it receives, you know, the number of times it appears elsewhere. The most cited paper on massage was actually written in a psychology journal. And the third most cited on massage was cited in another psychology journal. And, you know, if you look at the top 10, actually massage pops up an awful lot in psychology and psychiatry when you're looking at it. So that's sort of where my talk ends up going. You know, we've got a BPS model we're working with here. And so maybe it's time to reconsider where massage sits within that scope of practice. Still has a place, but perhaps it's been slightly ill-judged over the last few years.
So a bit of melting fascia and realigning sacroiliac joints, those sorts of things.
Love that stuff.
Yeah, and I know that's what Chris loves to do as well. So yeah, I mean, I also heard I was on the stream on Monday with Meekins, and I know that there was sort of a little bit of a gauntlet thrown down that you wanted him to attend your talk and ask some difficult questions. But I think I think that will be, you won't have any problems there. I think that'll be fine. But it's one of the things, like I said, we've got Leah as well, and we'll come to you in a minute, Leah. But it's one of the things we wanted to get into this conference is, obviously, if you, like you said, if you take a very narrow view of what massage is, then it's taken a bit of a battering. But obviously, there's a lot of people that find it very beneficial, and you have to try. We're trying to marry up this scientific narrow view with what actually works in inverted commas for individuals, and it's a difficult line to tread sometimes, isn't it? It
is, absolutely. And yeah, I sort of don't want to steal from Leah as well, because I'm, you know what I know about Leah. I think we sing from the same hymn sheet largely, but essentially there is the sort of the arguments, it's been around forever, so clearly it works, and that doesn't sit well with me, because I want to know why it works. But when we get too deep into the evidence, and if it's not in a paper with decent results, then I don't use it. Well, then what you're relying on is that the correct questions have been asked and that the correct tests have been run against those questions. And, you know, within medicine, we are quite biased towards quantitative research. We want to be able to put numbers to things. When you branch out into areas like psychology, which is where neuroscience sits, and of course we're quite happy that pain is a neuroscience topic nowadays as opposed to a physical topic. When you start to branch out into psychology, then all of a sudden you're looking at mixed mode research, you're looking at qualitative research, and there are some really good research methods out there. And I think that's possibly an area that massage has a bit more scope within. Because it's really hard to do quantitative replication of a randomly controlled trial, double-blinded, when have I massaged you or not? You know, I mean, even sometimes I don't even know. So how the hell the client would, I've no idea.
No, exactly. Very difficult. And that brings us actually really nicely to you, Chris. And we had Thomas doing the mobilizations with movement of the upper limb, and I was really keen on getting someone in to do lower limb, because I think there are some significant differences. Obviously there's a bit of a difference between an arm and a leg, but I think there's some treatment modality differences as well. And when I was thinking about it, my brain process was going, who can I ask that's going to strike that middle ground where it's used appropriately and sensibly, but isn't dismissed and thrown out? And the first name that came to my head was Chris, and Chris said yes. And I was like, brilliant. On he goes onto the stream and talk about lower limb manual therapy. So tell us where you're going to go a little bit with your talk, Chris, unless I've just completely blown it out of the water.
Yeah, I mean, my background is I'm an old git in that I qualified in 1981, so sort of 40 years ago, and think the profession has sort of evolved through that time. And I think we all tend to gravitate towards our original training. And I trained originally as a now long since defunct profession called remedial gymnastics. And so my area has always been exercise, and I've always tried to avoid defaulting back to exercise all the time, and try to be open-minded. However, both my master's and my PhD were on the sort of exercise side. So my take on manual therapy really is to use an integrated approach. So I'm not a member of any large organization. In 40 years, I've done all the various different courses and bits and pieces, but I tend to use it as a precursor really to rehabilitation. I'm aware of all the science, both quantitative and qualitative, behind it. I think it has a use, but I think it's a double-edged sword. I'm not the sort of person who says, well, you need to do 3, 4, 5 years training to be a manual therapist. It's highly skilled, etc. But equally, I'm not the sort of person who says it disempowers the patient, let's throw it out. I think there is a middle ground. Sometimes that's criticized, where people will say, well, you know, if you've got so many tools in your toolbox, you're not focusing in on the one thing. And that assumes that you can focus in on one thing with a human being. And I don't think you can. I don't think you can. And I think if you look at the qualitative research, it would suggest that, you know, if we're multifactorial, then our treatment has to be multifactorial. So what I'm going to be doing is looking at some of the evidence, looking at the sort of biopsychosocial aspect of manual therapy, some of the research behind that, and using some 3 sort of examples on hips and knees, really, and saying, well, okay, this is the sort of classical way it's taught. This is the way I do it, and this is the way I change it, and this is the way I use it to instigate a rehabilitation program. And, you know, partly evidence-based, but not as science-based. And I think that is perhaps one of the criticism of our profession. Certainly from the 1980s, we have become very science dominant, and obviously that's only one, you know, it's a vital part of the evidence, but it's only one part of the evidence. And other professions, certainly social science professions, have sort of flipped round a little bit, and would argue that, you know, the way that we're doing things is perhaps, you know, incorrect. And, you know, that's the thrust of my my talk. Will be when I've written it.
I can see Matt's nodding so hard his head's going to come off. Yeah,
absolutely. I think me and Chris are going to end up having a virtual beer at some point at the back of this conference.
I totally agree with you, Chris. I mean, I think the point you made about treatments having to be multifactorial, I think we can narrow in even further and say individual treatments act in multifactorial ways. So you've got a multifactorial human being with multiple treatments being applied to them, and each of those treatments act in a multiplying different ways. Like you said, if you take exercise, there's no way that a strengthening exercise only strengthens muscle. Like there's lots of other applications to it, and I think that's certainly where I see these things. And I think we haven't got Oliver Thompson with us this evening. I can't remember, he was supposed to be joining us and just hasn't made it, but he's going to be talking about the language around how we use manual therapies and physical therapies, and I think that'll be a fascinating talk to tie together what you and Matt have just said.
Yeah. I mean, I think, you know, we're very keen on patient-specific treatment, but then we tend to ally ourselves towards science, which is not sometimes patient-specific. And, you know, don't get me wrong, I'm not saying that you know, we need to get rid of all the science, far from it. But I think sometimes we can be very, very selective to support our own bias. And you know, we're all guilty of that. But as a profession, I think sometimes we've sort of been throwing the baby out with the bathwater a little bit.
Definitely.
Leah, that was a profound baby.
Yeah, Leah, that brings you on perfectly to us, onto yourself. So I know we've sort of, it's a little bit similar to Matt's talk, but with a different slant on it. So tell us a little bit about, firstly, your background, but also your talk as well.
So I'm a remedial massage therapist in Sydney, Australia. I used to be in IT, and before that I was an English teacher in Japan. So this is my 3rd career, and hopefully not my last either. So when I was training, I had a very different experience from Matt, in that I was taught all the old stuff, all the old school massage stuff. And I think the main focus of my talk will be reassuring other professionals, multidisciplinary professionals, that there are a lot of massage therapists like me and Matt who don't believe we have magic hands. And I think that's a really, really important thing for everybody else to know. Massage has a very well-deserved bad reputation for being incredibly steeped in a lot of woo-woo and pseudoscience. So when I trained, fortunately, very, very fortunately, halfway through my year, I discovered painscience.com, and that's run by Paul Ingraham. And when I read his very, very long article called Does Massage Work? I almost lost it, because I just spent $15,000 on a year-long diploma, and Paul had just told me that everything I was learning was crap. So, but at the same time, it switched gears in my mind, and I graduated with actually in a completely different direction from everyone else, because I felt like I discovered the truth. So I'm a remedial massage therapist, but I also live with persistent pain. I was diagnosed with cervical dystonia about 14 years ago, and massage therapy was one of the only treatments that really helped me. And so I developed an interest in it, and I've been very active in the chronic pain groups in Australia. I'm a member of the Pain Australia Consumer Advisory Group. We've done a lot of work with the TGA here and NPS Medicine Wise, opioid fact sheets, education fact sheets. I'm also a member of the committee to revise and update the Australian Diploma of Remedial Massage, which is done about every 30 or 40 years. No, not really. The last time they did it was about 6 years ago. But we've also been tasked with creating an advanced diploma, which is extremely exciting, because I think there are a lot of massage therapists out there who are looking for more, and they're looking for, I think, well, really just more evidence, just a different approach. And I think instinctively, I think a lot of massage therapists have understood the BPS framework, but didn't have a name for it. And because we do spend a lot of time with clients, I mean, which other profession gets to spend a whole hour listening to their clients? It's us. And I think that's a huge advantage. And if we start to understand the BPS framework and stop this nonsense of I'm changing your tissue with my bare hands from outside your body business, then we're really going to get much further than we ever had before. So I'm really excited actually about this point, I think, in history for us. And I think that I really love massage. I think it's a great therapy. I think it's a great profession. There's a lot of crap in our industry, and there's you know, people will often look at us sideways like, yeah, there's a lot of bunk in massage, but I think there's a lot of great stuff in massage, because most humans love to be touched, and they often feel better when they walk out of the room. But as an evidence-based massage therapist, I really want my fellow massage therapists to, bring themselves up to speed, up to 2020, and understand that they are doing great things, but for different reasons. There's a lot of reasons why people feel better. And it's not because we're busting adhesions and dissolving trigger points and rearranging their fascia and things like that. They do feel better legitimately, but for very different reasons. And I think massage therapy for chronic pain is fantastic. It done in a nice calming way can calm someone's nervous system, which, as we know, plays an integral part in persistent pain. And to quote, I think it's Greg, our role is to calm shit down so that you guys can build shit back up again. And that's really what we are doing.
Exactly, spot on. We've just had a comment on the live stream from Mike James, and he said because he doesn't know who to pick from all the things, he's choosing on accents, and you're winning that current battle, Leah. So you've got one viewer based on accent at least.
And you know what the funny thing is? I was actually born in Hull, and so I
wouldn't
could
say
have
that too loudly.
But I moved to Canada when I was 3. And I arrived in Australia 22 years ago, and I have not lost my accent, obviously, but after 22 years, I can say mate properly. I can do that now. Taking a lot of practice. Brilliant.
I think your talk is going to be incredibly popular. I think it's going to be chocker full. Paula, onto yourself. I think, to be honest, you're going to have the hardest sell job of anybody. If we say manual therapy's taken a beating over the previous, but tape has taken one hell of a beating when it comes.
Yeah, thanks for that.
Yeah, no worries. I'll throw you in a looping ball there. Yeah. Of all the treatments that I can think of, I think tape has to be up there with one of the ones that's taken the biggest battering. So how are you going to dispel that myth that we should still use it a little bit?
Well, I think the start is when I get a message going, Paula, do you want to talk about tape? And I'm like, okay then. Because I do use it for various reasons, but so I will talk about that. But I was like, I feel like I'm being set up to fail here. However, so a little bit about me. I have quite a long history in elite sport as a physical therapist. So very steeped in soft tissue therapy, manual therapy, as most people that work in elite sport are. In fact, at one stage, we would bring therapists over from places like South Africa and Australia because they were so good at manual therapy. And traditionally, some of the physiotherapists in the teams and stuff weren't that great. So that's over 20 years of working in elite sport. I have private practice as well, and I also am a clinical advanced clinical specialist at a private hospital running their sports injury clinic there. So I do quite a lot of bits and pieces. I do have a big background in soft tissue therapy as well. So I am, I know Matt. We met at doing Help for Heroes stuff for the Invictus athletes, which was awesome. And so again, talking about some of the stuff that Leah's just talked about, how incredibly important sort of massage stuff is there because of their histories of PTSD, etc., and enabling them to be able to function as an athlete in a very highly charged environment where guns are going off on the track, for example. So there's lots of different aspects I'm sure these guys are going to hit upon. Again, I'm going to talk a little bit about why I guess there is a history of lots and lots of therapy dependency within elite sport, and I'm definitely not an advocate of that at all. I've been told before, get deep, just keep doing it deep, and you sometimes you have athletes that walk because you're not going deep enough, or somebody isn't going deep enough. So there's an element of pressure that comes from, especially if you're fairly new to sport, pressure that comes from just do what you're told, and athletes vote with their feet. So if you don't do that, off you go, kind of thing. But saying that, they are working in with marginal gains, and there are sometimes people can't compete, or they can't finish a training session, and their coaches, coming over, the biomechanist is saying they're not doing this in a right way, etc., etc. A little bit of jiggery pokery, and then all of a sudden they can. So whether that's a massive afferent input or whatever it is, fundamentally things change and they're able to finish a session. So if you're looking at the history of how why that can become therapy dependent is dependent on the therapist saying you need me, you need me, you need me. But fundamentally, there are tools that we have all available. And talking about manual therapy again, you know, there are certain things that we do over our history, like I said, 20 odd years of working with athletes, where I've tried not doing anything. I've tried only doing exercise rehabby type stuff and only doing soft tissue therapy type stuff or manual therapy type stuff. And neither of them work particularly well on their own, except for some injuries and some difficulties, okay? But what happens is that if you put those two together, what a perfect marriage, in my opinion. I see the results, you know, it can be performance impacting. And so therefore I get, whether that's my bias, but I definitely get swayed in that direction. Coming to tape, when I say tape, I can only talk about dynamic tape. I've tried every other tape on the market and it does nothing for me or for the athletes that I've worked with. And they've lasted, I've tried them and they've ended up being binned. I don't have any affiliation with dynamic tape at all, but what I do find is that when it comes to somebody that can't necessarily finish a training session again, or can't finish or can't rehab because of pain, dysfunction or positioning, that this tape kind of comes into its own. So I'm quite happy to talk about that and the fact that it has made an impact on certain people and the way they're able to continue to function. It's a different type of tape, it's a biomechanical tape, and whether again that what the research behind it is, there is emerging research behind dynamic tape, which is better than the traditional rigid and kinesio tape, the cotton kind of built tapes. This is much more as kind of a lycra mixed with, it's very, 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 very elastic, like a bungee cord. And what it's supposed to do is kind of re-inject elastic recoil into the tissue. So therefore, if somebody is struggling to get their heel up, it can help kind of bounce that heel back up. So you can see the results, you can see things happening, and the athlete, again, we go to qualitative stuff, whether that's research or not, and the athlete will come back and go, I can't feel that now, I feel like I'm hitting the ground. Biomechanists will film it and say, that's a much better position for that foot now. And they're, you know, sold. So, you know, so there's, I can't necessarily, all I can do is talk about it in practice and with my experience, and just say that there's times I use it and it's incredibly efficient, but it's not something that I go to. It's not, I don't just suddenly go, I'm going to go to that. I'm going to do that with every single person. Everything's individualized, as with everybody we're talking today. So sometimes somebody will need it. I say need it, it could help them. And other times there's just like, it's just not necessary, just like with every other adjunct.
Yeah, and I feel like you might be ignoring my text messages from these days onwards.
Yeah, I was like, what?
No worries. So Benoy, finally to yourself, and you've got a really interesting task in that I think with your topic, we're almost arse about face compared to everybody else. I think we're fairly certain that shockwave has an effect, but we're still banging on about when do we use it. So yeah. I'm hoping in the 30 minutes that we're giving you, you're going to solve all those problems for us.
Yeah, so a bit of background. So I work as an MSK physio, mainly as an advanced practice physio, 3 days in the NHS and 2 days I do private practice. So it's sort of, I can have the best of both the sides, both in the advanced role as well as treating like normal day-to-day patients. And prominently my role is lower limb. So, you know, I'm not treated, I don't remember the last time I treated a shoulder or elbow. So I stick with my hips and knees and foot and ankle. So the thing is, if you look at the research, we all agree the gold standard for loading, you know, for tendinopathy is loading and rehab. But look at the research, and somebody who's been like a physio for 20 plus years, like myself, will know that exercise works really well, but it's not the panacea for everything. If you look at the stats, it's around 60% for Achilles and patella. So there's a huge number of patients who are not improving, and that could be many reasons. One, they are not loading enough, or you know, they want a quick fix. You know, when you tell them it's going to take 12 to 16 weeks, they say, is there something you can do quicker? So I would say that clinically there's at least 30 to 40% of patients who don't get the desired response with progressive loading in 12 to 16 weeks. And I think there was a systematic review by Pete Malalis and Kristen Barton, which sort of, the numbers was around 60%, which showed like 40% don't really get that result. So those people are going to go somewhere. So they're going to go for PRP injections or dry needling or shockwave. So, you know, they want something quick. And that's where I think for me is, before you try anything invasive, you want to exhaust a non-invasive option. So all the Shockwave has been around for 20 years. I would say this explosion is only around the last 3 years. And I think it's a lot of things is by external factors, like I think the market factors. For example, the price of the machine is nearly half what you could get like 5 years ago. The second factor could be insurance companies. Like 2 years ago, Bupa and AXA wouldn't really repay the money if a physio gave the treatment. So I think in the last 2 years, they approve physios, osteos, and sports therapists. So I think a lot of things what we do sometimes is driven by external factors, not purely by evidence. I don't think the evidence has changed massively in 15 years, but for the last count from commercial factors, I can see there's at least 15,000 clinic, like 1,500 clinics offering Shockwave. So it's a reflection. So I'm not here to convince the Shockwave. The reality is it's been used tremendously. So what I want to bring here is when I started the journey about 8 years ago, so I was given like a half-an-hour lecture by a salesman and said, this is what you do. You give it three times once a week, and this is the setting. There was absolutely no reasoning, no idea what to do with the machine. So I asked my manager, why do you want to give 3? Why not 5? Why is 2.5 bars? So a lot was very technical driven, and I'm not happy with that. So I like to know why, why should you give only 3 times? Why not 5? What's wrong with 8? Or what stage you should give. So that's sort of gone on my personal journey, because I get a lot of runners with chronic proximal hamstring, things like that. So I think the main area of the talk is to see how that fits in. And I think for me, I think it as a purely desensitizing tool. So I don't make a complex explanation with a patient. I say, it's a pain numbing tool. And if you look at Shockwave, it's used in, and the problem with Shockwave is it's got different names in different countries. So if you go to the States, they don't call it Shockwave. They call it like EPAT, something called extracorporeal pulse, something. And if you go to like a beauty salon for cellulite, it's the same machine. They call it acoustic wave therapy. And if you go to Switzerland, they call it pressure waves. So there's a lot of confusion on the terminology. And so the aim of my talk is to standardize it and saying what it is, what's the mechanism, at what stage you should be giving. And it's one of the reasons where Shockwave gets a bad reputation is it's given as a first line of treatment. I only offer Shockwave for people who have done at least 12 weeks of loading. So it's always the second line of treatment, only for people who have failed conservative management. So if a patient has not responded and it's chronic and it's stable, but they're not getting improvement, and the pain is still stopping. So that could be a factor. Now, the mechanism, to be honest, is I've been trying to scratch my head on it for 10 years. And the thing with Shockwave is it's the same device, but it's used in different settings. So it's even used in erectile dysfunction. So how do you explain a machine which works for tendons, muscles, kidney stones, and on penile structure? So it's a bit of a problem, really, because it's the same device which you use in different settings. So clearly the mechanism is more cellular level or something. So the exact mechanism is not really known, but what we know, there is a pain inhibition effect and there's a pro-inflammatory effect. So there's definitely swelling. So I guess it's sort of like anything else. It kickstarts the healing process. The advantage for me is it's quick. It takes 3 minutes. It's non-invasive. I find it's a great tool to get people back. So the thing I find where practitioners do is the way I or I sell to the patient is I say it's 3 + 12. So what I mean by that is it's 3 weeks of, I give a Shockwave once a week. So it's 3 weeks of Shockwave plus 12 weeks of rehab. So, and when they hear that, they're a bit disappointed. They think like I'm going to be running in 4 weeks. So it's much longer than you think. It's definitely not a quick fix. So maybe it's a tool to buy in the rehab. And there's something about human nature. When you have a gadget or an injection, your compliance is much better. So I think it's more the loading and the compliance which makes it more effective. So that's my sort of view on that.
Brilliant. It's definitely what talk I'm earmarked into. I'm glad you said you didn't understand quite all the effects of Shockwave, because I've taken a little bit of a dive into the research to try and work it out, and my brain started coming out of my ears. So I'm glad that to hear that you, after a number of years, came to the same conclusion. We've had a question, Benoy, from the live stream, which was from Mathew Wyatt, and I'm going to open this up to everyone else as well after you've given a stab at it. And this is a recycled question from one of the live streams the other day. And he says, if you're good at rehab, do you actually need adjuncts and physical therapies? And I think you're a perfect person to start with that question. And I'll open it up.
So, I think Mathew would, Mathew sits in, like most people who work as an advanced practice physio, we sit in a position where we see people. I only see patients who have been referred by physios. So obviously they've been done on physios. So I would say the majority of cases is the rehab has been incomplete, either because of the loading has been poor or because of patient's compliance. So in theory, if the loading has been good and the rehab has been good, there is no need for adjuncts, but people don't do what we say. So if you look at the complaints to exercise from a systematic review, it's around from 30 to 70% of people don't do what we tell them. They don't follow the protocol. So it's as if it's as simple as people follow the rehab, then you don't need any gadgets. So the reality is there'll always be a small section of people who either because external or other factors, they don't really follow up. So and those people, like if you don't offer a substitute, it's a try system, isn't it? And saying like, okay, let's exhaust rehab. If that fails, then maybe try shockwave. If that, then we can send you to the surgeon. And most surgeons, like foot and ankle surgeon, don't want to operate an Achilles tendon. They don't want to operate a plantar fasciitis. And steroid, especially post-COVID, is going out of fashion. People don't want to put steroids in. And in private practice, you don't want to be wasting, like spending 2,000 pounds on a PRP injection, 3 injections. So, it's not perfect, but if something which is non-invasive, doesn't have, it's been used in human tissue for 40 years. So it's got a very safe profile. So, it's an option there. So I'm not saying like it should be the first, but, if you've been as a physio, you will know that, that people don't respond. There's always going to be a subset of people who struggle with the symptoms, and it's our responsibility to offer something, isn't it? If somebody comes to me like with a painful decurrence, struggling with a baby, you would offer a steroid injection in those instances, or a stage 1 frozen shoulder. So you can't just say it's going to get better in 1 year, or so that's the reality when you work in NHS or in the private setting. So you have to be pragmatic with all we do, isn't it?
Perfect. Exactly, I would agree. Thomas, I've got a question from Andrew Cuff for you, so you know that this is going to be a solid one. He says, "Is that a real skull behind you?"
Yeah, well, that's I suppose in the old days of training, we were all given half skeletons, and I had one when I was at university. But then, strangely, through working in the murky worlds of training and going across Europe to seek out people who are very good manual therapists, you end up sort of entering into this weird black market, and a real human skeleton came up, which came to pass, and it got left to me. So yeah, that is a real human skull.
It is a real human skull. Brilliant.
Let's get back to Matthew White's question. I think that's
yeah, go for it.
It's an excellent provocative question, as in, if we're doing the basics, like if we're getting the core treatments in, what is the purpose for adjuncts? And I think it's really hard to affect behavioral change in people. So it's really hard to get people to comply with exercise, to comply with loading. And if we look at the work of Mary O'Keefe through some of her qualitative work, we also look at the studies of Kirsten Jack and Shona McLean, who looked at what influences therapist and patient interactions. Things like being on time, having a uniform, being nice to the patients, empathy, all these things are very much very important within that change of behavior and the effectiveness of treatment. So if we start thinking about things just about loading and core treatments, we're looking at a meaningless, we're looking at something which is trying to apply meaning in an extremely complex environment. So for those people who, people with problems are like complex locks, and if you need different keys to unlock different locks, and unfortunately there is no one size fits all. And I'm very much a believer in following the loading, doing the core treatments, educating, showing empathy, and all of these things. But I think to disregard things that have been useful in our clinical experience because of let's cut to the chase and just focus on the core treatments, means that you will miss a proportion of the population. But hopefully, as we know more, we'll be able to understand more about how to affect behavioural change. And as I spend longer in my career, it seems more and more that we're dealing with population health issues when we're dealing with musculoskeletal things. So I think if we really cared about reducing pain, reducing musculoskeletal problems, we'd be looking more at kind of population level changes like junk food advertising being banned, active transport over car usage, valuing community institutions like youth clubs, and getting people to know their neighbours rather than this kind of global isolated society that we're living in. But yeah, there's many ways to treat MSK.
I think if I can jump in.
Go for it, Matt.
I think I really like the analogy, different locks need different ways of unlocking them. And going to the global side of things, I think one of the areas where I'm seeing massage therapy fit is in the mental health space. Particularly when we're talking about pain, either complex or persistent pain, and we're quite comfortable with the biopsychosocial model being all right. People argue over the exact mechanisms of biopsychosocial, but in general, there's the bio, there's the psycho, there's the social. We're quite comfortable with that. And I think the bio side, the rehab, the strength and conditioning is absolutely where we should be trying to encourage people to get to. But I think some people need the psycho addressed and the social addressed. And again, looking at the evidence, massage has the greatest weight of evidence, I suppose, and high quality evidence in its effects on anxiety and depression. It's not unknown that persistent or chronic pain, complex pain comes hand in hand with anxiety and depression. And they kind of end up in a bit of a vicious cycle. So, if you've got someone who is in too much pain or is reporting to be in too much pain to do your rehab exercises, why wouldn't you offer them something that is in your skill set and has been shown to help their mental health, which could have the knock-on effect that actually they become more compliant in the rehab side of things. So I think, I think with that population, you're almost doing them a disservice by not addressing that more global health aspect to their background and to their psychosocial element. And I think the other bit that's quite easy to fall into a trap, particularly therapists who exist just in private practice. Obviously, it's different for practitioners who deal with NHS and get a broader range, but particularly in private practice, when we look at our own clinical experience and we make judgments based off our clinical experience, we have to remember that by definition, the set of clients we're seeing in clinic are biased already. They have responded to our marketing. They've responded to our personality that we put out there. And, if all you are is, I'm going to have you in the gym and you're going to be working your ass off for me, you're not going to get someone who is mentally fragile and needs a bit of TLC. So you're not going to see that element of the population. So you're not going to have that kind of, yes, I need to be mixed mode. You might be like, well, everyone I see it's successful with. In a little bit way, if I'm a little bit more, I'm trying to think of the right word. If I'm more open when I'm discussing things like mental health, if I'm more open when I'm discussing a little bit more gentle, perhaps in my marketing, I am more likely to get people who respond well to the massage, and I'm less likely to get people who come in going, make me look like He-Man.
Yeah, for sure. Chris, you look like you've got something to add. I'll come to you as well, Leah.
Well, I think that there are thousands of points there. I mean, I think to get back to the original question, if our rehab is good, we certainly don't need adjuncts as much. But I think it's not an either or. It should be that we're using an adjunct to empower our patient to do the rehab at that particular time in their healing timescale for that particular patient. So, if we're in an acute phase, we might choose to use an adjunct to enable that patient to engage in rehabilitation earlier than they would perhaps without the adjunct. But I think when we get into the situation where we're using an adjunct simply because the patient wants it or we're pleasing the patient, I think that can be dangerous. You know, we should be a profession, you know, obviously very biased towards exercise, but we should be a profession who's trying to enable a patient to go on a journey which gets them to be in, you know, in a rehabilitated state, and gets them to, you know, to build their confidence, if you like. And I think adjuncts can help with that, but they can also interfere. And I think we need to be cautious that when we're going along that journey, that we're willing to chop and change depending on the patient's reaction.
Perfect. That beer just got a little bit longer, didn't it, Matt? Leah, you patiently had your hand up, so please do go. You've had some lovely comments, by the way, on the live stream about fitting massage into the biopsychosocial model. So keep going.
I will be talking a lot about that. I guess my short answer would be it depends. You know, humans are complex creatures, and everybody succeeds in different ways. And some people need a little bit of this and a little bit of that, and others need to just get straight to the point, and they're very dedicated. And, you know, for me, a lot of massage is about a bit of TLC, taking the load off, flopping onto the table, and letting somebody just soothe and calm and give them a break. And sometimes rehabilitation it's hard work. And I think where massage fits in is it's a little bit of you know, just calming and soothing. And we're not doing magical things with our hands, but I think with a lot of clients, they get up and they say, oh, that was magic, or you've got magical hands, because they've just had a really nice hour to themselves in a dark room with a sympathetic, kind person. For me, one of my adjuncts, well, really probably my only adjunct, is education. I also am on the Pain Revolution Communications Committee. So we work really hard on educating the general public and professionals. And the lovely Mary O'Keefe is the head of that. So I get to meet with Mary about once a month and talk about lots of stuff. But I find that education is a really, really important adjunct for me, because often people come in with a lot of confusion around their pain. Often they have had a bazillion scans. They've tried physio, they've tried osteo, they've tried chiro and acupuncture and massage. And there are still a lot of questions. They haven't been able to connect their pain dots. And explaining to people about the biopsychosocial of pain suddenly gives people this, oh, wow, I had no idea. So for me, pain education, pain neuroscience education is a really important adjunct of my job. And look, I don't sprinkle pain education over everybody, because sometimes people just want to flop on the table and go to sleep. But for people who start asking questions and who come in with long-term persistent pain, I think it's a really, really important thing to do, to explain pain to people.
Definitely. And you'll be pleased to know Mathew has commented that these are better answers than in the rehabilitation stream the other day. So that's high praise indeed. Paula, I'm not...
One final point then.
Very quickly, Chris.
With what Leah was saying, we have to be careful that these manual therapies don't become addictive, because we are ultimately, with our rehab, trying to build resilience, whether it's mental or physical or a combination of both, hopefully. So that's perhaps a little bit of a rider there.
Perfect.
I think that's where the education comes in. Oh, sorry.
Yeah.
No worries. We're running out of time, and I've got an absolute barnstormer of a question for Paula. So I just want to get that in because I also want to get the agenda up for us all to get excited about. So Paula, I do feel like a bit like I've thrown you under the bus. But anyway, so Andrew McCauley asks, if an athlete needs tape to finish a session, surely this is more a psychological issue then that should flag an adjustment in the communication between therapist and athlete. This therefore begs the question, should we just get better at communication and athlete relationship rather than applying a tape?
Yeah, did I say that did I say that? I must have said that. I didn't mean that. So no, yeah, you don't need to tape an athlete to get them to finish a session. That's ridiculous. So yeah, it's used in when we use tape, we use it for various reasons. It's usually, again, it could be because an athlete, I'm not just talking about athletes, obviously have private practice as well. If somebody's function isn't particularly good and their pain is quite high and they're unable to commence their rehab or continue with the rehab, it can actually modulate some of the pain according to them and enables them to walk, enables them to kind of do certain kind of rehab exercises. Similar things within athletes. You wouldn't be doing it, you wouldn't stop them mid-session and just stick a bit of tape on because that's just crazy. But it would be potentially part of the program. And like I said, tape isn't used for everything. It has a place, but again, just like all the adjuncts, it has to be clinically reasons to why you're using it. And it has to have some form of effect, whether that is a psychological effect at some stage. If you're in a competition and you suddenly have to go and they've come back to you, they've done their warm-up and there's an issue, and if that gives them a bit of a boost, it's not usually used like that, I've got to say, but again, with the other adjuncts, sometimes to just give them a psychological boost because they're nervous or whatever. I've never used it in that way, but you can see how it could be used in that way from in other people. But fundamentally, you know, it's a clinical reasoning, individualized approach, looking at what a person needs and basically trying to affect change and affect performance in some way, however you need to do that. And like Leah's just said, the number of people coming to be private practice that have been to see every therapist known to man, and usually it's because of a poor rehab program. And again, these adjuncts are just there to kind of support that rehabilitation program, in my opinion.
Perfect.
Can I just, I'm sorry about this, but
very quickly, Chris.
Go back to the first question. Taping is a form of communication because it's tactile cueing.
Yeah, shut up, Andrew.
Sure. Can I throw one in? I'll throw one in as well then. And just because I completely agree with Chris, you know, we need to avoid clients becoming reliant on hands-on. But is it the adjunct or is it the therapist that creates that dependency?
Very good question. We don't have time to answer that now.
Expecting an answer from that.
No, I like throwing in just sort of big rhetorical questions.
And Andrew says, no worries, he thought us back. Sorry if he misunderstood. So we sorted that problem out. So very quickly, because we've run over time already, because this is such a good conversation, and is vindicated my entire justification for putting this whole stream in. So we'll just go around. Benoy, I wanted to start with yourself. Is there any? Have you had a chance to look at the agenda, and is there anybody that you're particularly looking forward to hearing from? Is he there or is he on mute?
He's gone. He's gone home.
Oh, he's gone home. Ah. That shows.
Had enough of this. Oh my God.
Yeah. Let's go with you then, Chris.
Well, I think this Jack Marsh guy looks quite good. I know nothing about rheumatology, so yeah, that looks quite good.
I would agree with you. I think it's going to be the best talk of the day. Perfect. Thomas, anybody? I know you said an amazing accent I think you were looking forward to down at the bottom here.
Who's that? Oh, Mary O'Keefe, Greg Lehman, absolute legends, especially especially looking forward to hearing Derek Griffin speak as well with the exposure therapy, which I think has some good utility. But I've got to give a shout out to the Sheffield and Yorkshire contingent. So Val Jones and Andrew Cuff for their upper limb work should be excellent as well. I think also Mike Stewart is someone I've followed for a long time now. I'd be really interested to learn about his thoughts on pain. So it's a brilliant lineup. Stellar.
Excellent. Matt, how about you?
So I'm going to be listening to Leah because I think Yeah. Basically, she'll feed into mine, which is immediately afterwards. So I'm just going to steal everything that she says. But otherwise, no, I'm going on titles, and I quite like Ollie's. What do you mean functional?
It's a good title. Yeah.
I love that. So I think that one's won me.
Brilliant. And yourself, Chris? We did yours, couldn't we, Chris? Sorry.
Yeah, although I've just seen that Anna Schmidt is there. Well, I have quite an interest in her work. So yeah. I think she's probably on. Is she on at the same time as me? No, she's not. She's not. So I'll go there as well.
She is on the same time as Matt, though, so Matt's going to miss out on that one unless he watches afterwards. Leah, I'm particularly interested in yours as to who you're looking forward to seeing.
Well, I really, when I look, is it Paul? Can you scroll down a little bit? Yeah,
Paul Coker, yeah.
When I saw that one, I thought, ooh, that looks good.
That will be good.
That one, that interests me. But I'm actually taking the day off so that I can prepare myself for the night and join as many as possible. Adam is always good value. I really like listening to Adam. He's a straight shooter. But definitely Ben and Greg, my fellow Canadian, Derek, Oliver. We didn't see Oliver today.
No, it's down here. Yeah, shifting the conversation, the language. That's going to be a really good talk.
And definitely Matt and yeah, there's just so many, and Mary again, as of course. There's just so many really good presenters. I was so tickled when you guys messaged me and asked me to be part of this. I was really super surprised as well.
No, you jumped on our radar as someone talking sense.
Yeah.
So that's always what we like to get on our programs.
Are there any other Australians?
Pete Malieras is on. Where is he?
Right. Okay.
Can't find him now. He's in. There he is. 10:30 in the lower limb.
Right. Okay. But no other remedial massage therapists from Australia?
No, not that I'm aware of, no. So you can badmouth them as much as you like. Yeah, just yeah.
Because I will be talking from a specifically Australian view, because as Matt knows from all his readings as well, massage therapy is not standardized. It's not even standardized in, you know, the country that you happen to live in. So
you do have the advantage. You've got the Australian pain bunch. Like I am
the land of Mosley and Butler. Absolutely. So we're kind of lucky.
You're going to find Matt asking to come and stay with you for 6 months soon, Leah. That sounds like.
Oh, Leah is my new best friend. She just
Leah needs a say in that first, Matt. And then finally to you, Paula. Anybody you're particularly looking forward to?
Yeah, despite the heckle, I'm looking at Andrew Macaulay.
Yeah, you've got to think up some dodgy questions for it.
Yeah, I think that's and Claire Minshaw, because I really enjoy that rehab stream. I think Seth O'Neill's always got good value, and I think there's some good things on the business stream that I think might take me over that way. So I think I'm going to be looking into a little bit more into that and seeing what the timings are like.
Brilliant. Perfect. Well, thank you all very much for joining me this evening. We've run over by about 6 minutes. I'm going to blame Chris for jumping in so many times. All his excellent answers and our interest in Tom's real skull. So thank you very much for all joining me. I really look forward to the day, and I'll definitely be checking out as many talks as I possibly can. And I'll see you all then.
All right. Take care, guys.
Bye.
Thanks a lot.
Bye.